Good morning, all of my past, current, and future RNs, or any nurse thereof. I hope you all are having a wonderful day. I'm coming at you today because I just completed my PALS recertification. We have to do it. It's every 2 years, and this happens to be the years that my PAL recertification fell on. So I just took it about 2 days ago, and I thought that I might give you some helpful tips on how to pass the brand new PALS recertification. Now, I'm not sure what edition this is. I know it's a new edition. It was printed in October of 2016. Nothing really much has changed outside of pediatric, basic life support information, but we'll go over that a little bit later. But I wanted to give you some tips and some tricks to pass your PALS, whether you're taking it for the first time or you're recertifying. Let's get started. So one of the big things that they're emphasizing right now in the PALS initial as well as recertification classes is that they want you to know the difference between the JOULES of defibrillation as well as cardioversion synchronization. So to begin, if a child codes and they require a defibrillation based on their heart rhythm, then you want to start between 2 to 4 joules per kilogram for the initial shock. If the child requires an additional shock, the second shock should be greater than or equal to 4 joules per kilogram. They do not want you to surpass 10 joules per kilogram in a child, but they do have a really nice mnemonic, which is 2, 4, 6, 8. That's the dose to defibrillate. And basically what that means is you want to work your way up. So the initial shock is going to be 2 joules per kilogram, then you're going to go to 4, then 6, then 8, to a max of 10. You never want to go over 10 joules per kilogram. So in retrospect, the only thing left is synchronized cardioversion. So when a child goes into a rhythm such as SVT and requires a synchronized cardioversion, you only want to do 0.5 to 1 joules per kilogram. That is the max that they want you to go. Per the Pediatric Advanced Life Support AHA guidelines. However, they always recommend that you follow the guidelines of your hospital. These are just mainly guidelines set out by AHA based on best practices. So another big thing that they're trying to emphasize right now is blood pressure in children, because that's usually a very late indicator that something is going on once their blood pressure starts to drop. So when you're looking for a low systolic blood pressure on a child, it's so confusing because there's so many different age ranges as well as blood pressures that fall in those age ranges that you need to look for. But they actually came out with a very good calculation to help you understand low blood pressure regardless of the child's age. And that is 70 plus 2 times the age in years. So if you have a 2-year-old that comes in very ill, you want to do 70 plus 2 times 2, which would be 74. If their blood pressure is 65 over 40, something's wrong. That child is very sick and needs to be seen. You do have children that might not have age in years. Those are the ones that are less than 1 year old or that are neonates. So what they recommend is if a child is less than 1 year old and their blood pressure is below 70 is the cutoff, they're hypotensive. Or if you have a neonate and their blood pressure is below 60, which is the neonate cutoff, they also have hypotension. So you want to keep an eye out on those things because, children unfortunately compensate until they can't compensate anymore, and then they just crash. So let's talk about fluid resuscitation in kids. Fluid resuscitation in a child, they usually want you to do 20 mLs per kilogram of normal saline or lactated ringers over 5 to 10 minutes is usually the gold standard in regards to children fluid resuscitation. However, if you have a child that is a cardiac child or they're in cardiogenic shock, you definitely do not want to fill them up with fluids super fast, because in these children, you have to think of like an adult with CHF. When you have an adult with CHF, they're usually doing fluid restriction, not fluid resuscitation. So with these children, you want to do 5 to 10 mLs per kilogram of normal saline or lactated ringers. And really, it's going to be dependent on your facility in regards to how quickly they want you to give that based on the child's need. So let's talk about everyone's favorite subject, shock, because they do touch on this on your test that you take at the end of your certification. So there are 4 different kinds of shock. The first shock is hypovolemic shock. You've got cardiogenic shock. You've got distributive shock, and you've got obstructive shock. So let's kind of break down what falls into each form of shock. So hemorrhagic shock in children usually focuses around gastroenteritis, burns, hemorrhage, inadequate fluid intake, increased body fluid losses, osmotic diaphoresis, you know, things along those lines. Usually these are your children that come in and have been vomiting and they've had diarrhea and it's been uncontrolled and now they're dehydrated. So that's what you're looking for when it comes to hypovolemic shock. Cardiogenic shock is usually focused around, you know, congenital heart disease. They might have some myocarditis. They might have some cardiomyopathy, or maybe even like an arrhythmia. Cardiogenic shock is really focused around, you know, some kind of cardiac cause in regards to this specific kind of shock. Your distributive is your sepsis. Sepsis is huge right now in the hospitals, and unfortunately sometimes it's not always caught, but we're going to talk about that. Sepsis, anaphylaxis, and even like a spinal cord injury can be distributive shock. But I want to touch on sepsis. So what they teach you in the hospital is that when a patient comes in and they are in sepsis, they're usually going to have a low blood pressure, their heart rate could be kind of high, they're going to have a high white blood cell count, they're going to be breathing really hard, you know, things that you want to look for. Just an overall very sick presentation of sepsis, that you're going to look at this kid and go, this kid doesn't look right, something's wrong. And when you hook them up to the monitor is going to inevitably give you the information that you need in regards to sepsis. So be very vigilant of sepsis in children, because again, they compensate, and then they reach the point where they can't compensate anymore, and then they just crash. So be very vigilant in these children in regards to sepsis. And the last one we're going to talk about is obstructive shock. Now this can be an array of things in children. Tension pneumothorax, cardiac tamponade, pulmonary embolism, constrictions of their ductus arteriosus in infants. Sometimes with ductal dependent congenital heart lesions. Usually it's like a hypoplastic left ventricle. So you have a patient that comes in that's sepsis, and I just want to kind of touch on this real quick because it kind of confused a lot of people in the course. So a patient comes in with sepsis, and say their blood pressure's in the toilet and they're not breathing very well, they're not oxygenating very well. As a nurse, our first instinct is to go by ABCs, our airway, our breathing, and our circulation. However, according to the American Heart Association, they believe in a little triangle that's called evaluate, identify, and intervene. So we're evaluating our patient. We know that they have sepsis. How are we going to identify that? Based on our lab results, our vital signs, things of that nature, and we want to intervene. Well, their intervene is they want you to identify the cause of what's causing this patient to go south so quickly and fix it. So even though your patient might not be oxygenating appropriately, they want you to fix the problem. So what is the problem? The problem is that the child has sepsis. What is going to fix that problem? Antibiotic treatment. That's why when adults or patients, or as well as pediatric patients that come in, the first thing we do is we usually have a very quick turnaround time and getting antibiotics on board. So when you're taking your test, I want you to think about that, because they always want you to identify and intervene based on what is causing the problem. So again, if it is sepsis, they want you to treat the problem first, which would be the antibiotic treatment, and then move on to, say, other things. In real life, it doesn't happen that way, and I get it. But in American Heart Association's world, they want you to treat the problem. So talking about management of shock, what is it that they're looking for? They want to see you putting oxygen on these patients, checking their pulse oximetry, looking at the EKG monitor to see what's going on with that heart rhythm, getting IV or IO access, you know, BLS is indicated, of course, and making sure that you're checking that blood glucose. That blood glucose is important. Don't forget that blood sugar. You need to check that blood sugar. So with hypovolemic shock, if they are not hemorrhagic, they are not losing blood, you are going to give that 20 mLs per kilogram of that normal saline or lactated ringer as needed. However, if they are bleeding, you're going to want to transfuse packed red blood cells. That's just, you know, make sure that you understand that. Septic shock, you always want to follow septic protocol, and that's usually starting them on fluid, getting those antibiotics on board, checking that lactate, making sure you're getting those blood cultures, you know, follow whatever your facility policy is, because that's very important. Cardiogenic shock, usually, again, like we said, we don't want to overload them with fluids. So 5 to 10 mLs per kilogram, normal saline, lactated ringer bolus, and, you know, repeat as needed. Sometimes they might need a vasoactive infusion. And you also always want to consider expert consultation by contacting a cardiologist to intervene with this patient. So another very important subject that I want to talk on is respiratory diseases in children, because they really emphasize respiratory because it seems to be an ongoing issue in regards to management as well as proper identification. So forgive me, I'm going to look away from here for just a moment because I want to look at my screen. But they break it down into 4 different categories. You have your upper airway obstruction, you've got your lower airway obstruction, you've got your lung tissue disease, as well as your disordered control of breathing. Now, what falls into these categories? So with your upper airway obstruction, you're looking at children that have croup, anaphylaxis from, say, you know, an allergic reaction, aspiration of a foreign body. They were eating a piece of food and now it's lodged in their throat. Those are all upper airway obstructions. In regards to what you're going to see, there's always going to be an increased respiratory rate and effort. Regardless, all of them are going to have an increased respiratory rate or effort except for your disordered control of breathing, but we're going to touch on that in just a second. Breath sounds, that's what it's going to come down to. What is going on with those breath sounds? So you're going to have stridor, usually like an inspiratory because they have an obstruction in their throat. They have a barking cough. You're going to see that a lot with your croup, as well as some kind of hoarseness. Those are really the indicators of what you're looking for when it comes to upper respiratory obstruction. When you're looking at your lower airway obstruction, you're looking at bronchitis, you're looking at asthma, things of those natures. The only thing that is going to be different with your lower airway obstruction is you're going to have wheezing, and that's going to be typically on expiratory sounds. So you're going to have the that's the wheezing noise that you're going to hear. You're going to have a prolonged expiratory phase because it is a lower airway obstruction, and because you're hearing those expiratory wheezing, they're trying to get that air out of their body. So a lot of times that expiratory phase is going to be extended. You're going to have your lung tissue disease. That's you're looking at like pneumonia, pneumonitis, pulmonary edema, something maybe cardiogenic or non-cardiogenic. Usually ARDS is what falls into that. And the difference with that is you're going to have grunting. Grunting is a very, like I said, ominous sign. When they start grunting, you need to get help immediately. You're going to hear crackles. A lot of pneumonia, you just heard they're just crackling away. And also you're going to have decreased breath sounds. Depending on if they have pneumonia and depending on where it is, when you listen, you might not hear clear breath sounds in that area. Now lastly, disordered control of breathing. When you think of disordered control of breathing, you're thinking of neurological based issues. So you're looking at increased intracranial pressure. You're looking at potentially poisoning or overdoses or some kind of like neuromuscular disease. Those are never good things. When you do have somebody who comes in with this specific problem, you know, the respiratory rate and effort may be very variable. Their breath sounds could be completely normal and their air movement can also be variable. It's going to be hard to tell with these children. You're going to have to kind of know the background in regards to what's going on. So one of the things that they're going to want you to demonstrate when you are doing your PALS recertification is appropriate CPR on a child. So they state, per the American Heart Association, they want you to go 1/3 the AP diameter of the child's chest. So if you are a one-person rescuer, if it's an infant, you're going to push, 1/3 of the diameter of the chest, or if you've got 2 people, it is wrap your arms around the infant and push, 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 push. They want you to do chest compressions at 100 to 120 compressions per minute. And when it comes to one-person rescuers, it is 30 chest compressions to 2 breaths. And if you've got 2 rescuers, it is 15 chest compressions to 2 breaths. So make sure that you have that down and that you're prepared to do that, because that is something that they're going to test you on when you take your PALS certification. So let's talk about mega code. Mega code. Mega code. Everybody hates mega code, let's be honest. Mega code is one of the most stressful things because there is so much to remember in so little time. But I want to give you kind of a quick breakdown on the initial impression that you're going to do, as well as your primary assessment and your secondary assessment on your child. If you know this, you're going to pass mega code and you're going to be just fine. So your initial impression of the child. Your initial impression is what you see and what you hear when you walk into that room. You're going to go by appearance. What is their level of consciousness? Are they interacting with you? Are they interacting, you know, as children, you put leads on them and they want to play with them, or they don't want you to touch them. If the child is laying there and they're listless and lethargic, something's obviously wrong. Also, you want to make sure that you listen to the parents, because the parents are going to know more about their child than you are. But based on the initial impression, it's just pretty much what you see and hear. You want to look at their work of breathing. Is their respiratory rate high or low? Are they tachypnic? How is the effort of their respiratory rate? Do you see retractions? Are they really working to breathe? Do you see the nasal flaring? Do you hear any audible respiratory sounds? Are they wheezing? Do they have stridor? Are they grunting? Grunting is a very ominous sign in children. So if you hear grunting in children, that it requires immediate intervention. So the last thing that you want to look at on the initial impression is circulation. So what is their skin color? Are they looking a little dusky or ashy, or are they looking flush, maybe molted? Are they starting to look a little cyanotic? They usually get that nice cyanotic ring around their lips. That's usually a later sign. When you do their cap refill, how long is their cap refill? It should not be more than 2 seconds. Sometimes you might see it, 5 seconds in children. But one thing that I want you to keep in mind with children is a lot of times they're just cold. So a lot of times the capillary refill test may not always be the most accurate. You might want to warm them up a little bit and then try it again. That happens quite a bit that I've actually encountered in practice. So now we're going to move on to our primary assessment of the child. So now it's time for your primary assessment. This is your big boy. The rest is easy peasy, lemon squeezy. So you want to go based on A, B, C, D, E. And what does all of that stand for? So you've got airway, breathing, circulation, disability, and exposure. Now you're probably looking at me and going, what the heck is disability and exposure? I'm going to tell you, but let's start with our ABC first. So airway. When we're looking at a child, we want to make sure that the airway is patent and that they're actually getting good flow through their trachea. Now, one of the things that providers don't understand is that the circumference of the trachea in a child is much smaller. It's almost shaped like a cone. So if you have a child come in and they're like this, they're not getting much airway clearance. So you want to get them out of mom and dad's hands, get them on the bed, open their airway so that they can actually breathe in some air. Once we establish that the airway is patent, we want to look at their breathing. So breathing, is their rate regular? What about their rate of breathing? Is it increase? Is it decrease? How is their effort? Like I said, is there nasal flaring? Are they having inspiratory or expiratory wheezing? Are they grunting? Like I said, grunting is a very late sign. What about their chest expansion? Is their chest fully rising and falling back, or are they seesawing? Things of that nature. Are there any abnormal sounds? Like I said, with children, because they're usually covered up, to the nines sometimes because parents want to keep them warm, we have to take off all of their clothes. We need to see what's going on. We need to check literally every part of that child. So we need to take their shirt off. We need to take their pants off. We need to see what's going on underneath that clothing. So let's talk about that circulation component. We're going to look at the heart rate. Is the heart rate elevated? Are they tachycardia? Do they have bradycardia? Is their heart rate slow? We're looking at the rhythm. Are they in a normal sinus rhythm? Are they in SVT? Are they sinus tach? Are they sinus brady? We want to know those things. Blood pressure. Are they hypotensive? Are they hypertensive? Or do they have a normal blood pressure? Skin color, again, we want to look and check that skin color. We want to check that capillary refill. We want to check their temperature. Temperature a lot of times can be elevated or it can be low dependent on, the patient's condition. We're looking for cyanosis. We want to see how they're oxygenating. All of those things are very important when it comes to circulation. So now let's move on to disability and exposure. So with disability, you're looking at neurologic. You're looking at their level of consciousness. You're looking at their pupillary responses. You're looking at their AVPU. Are they alert? Are they verbal to stimuli? Are they respondent to only painful stimuli? Are they unresponsive? Those are things that you need to know. And the last thing, very, very important in disability, is what is their blood sugar. You need to be checking what is going on with blood glucose in children, because a lot of times that is the main opponent of what's going on. So in a neonate, if you have a neonate that is less than 28 days, 45 is the cutoff. If they're below 45, that's not good. Infants and children are 60. So if they're above 60, fantastic. If they're below 60, that's not good. You want to keep an eye out for that. And lastly, exposure. You want to see if you want to look at their temperature. You want to know what's going on with their skin. Is there any bleeding, bruises, rashes, things of that nature? You want to see what's going on in regards to the child's physical appearance in regards to their skin as well as their temperature. So you got through your initial impression and you got through your primary assessment. Now is the fantastic sample mnemonic of the secondary assessment. So like I said, sample is the mnemonic. It stands for symptoms, allergies, medications, past medical history, last meal, and events. So starting out with symptoms, this is going to be a lot of objective information from the parents or from a caregiver or whoever may be there. So symptoms, that's the observations. Again, increased respiratory rate, increased heart rate. Are they diaphoretic? Things you want to look for in regards to why they're there. Allergies, are they allergic to food? Are they allergic to meds? Are they allergic to any environmental stimuli? What are the reactions to those allergies? Those are things we need to know. Medications, over-the-counter medications, vitamins, supplements, prescribed medications, all of those things we need to know. And did the child get into anything they maybe shouldn't have gotten into in regards to, parents taking medications in the house or grandparents or whoever may be in the household. Past medical history, is there any previous illnesses, hospitalizations, are there immunizations up to date? Those are very, very important things to know, especially immunizations. They do have sometimes what they call herd immunity, I think is what they call it, where parents will not vaccinate their children, and they will take them to places where other people have vaccinated their children in hopes that their children will not catch what the immunization is trying to prevent. So those are important things you want to know. Last meal, when was their last meal? What did they have? Because a lot of times when pediatric patients come in, they might have to have surgeries, and those are very important things that we need to know prior to them saying having a surgery. Events, what led up to the current presentation? So was the child outside playing in grass at a soccer game and all of a sudden started having an asthma attack because they have a history of asthma? Those are things that you need to know leading up to the event, and unfortunately, those are things you're not going to know. You're going to have to get it from the caregiver, the parents, the coaches, whoever's there. So one of the last things I want to touch on in regards to the PALS is that PALS is an open book test. So of course you need to make sure you read it and understand concepts, but what's great about PALS is that they want you to know where to find the resources when you need them, because unfortunately, we see a lot less of pediatric advanced life support measures being needed in certain areas than others. Specifically in the ER, we might not have a pediatric patient coming in that's coding or needing these measures. They might just be coming in because they're a little sick, or you know, they have the flu or whatever the case may be. So they want you to know where to find your resources when you need it. They also include this handy dandy little card that comes in your book, which I'm actually going to scan so that you have a copy of it. But on the front of it, it gives you all of the normal rates as well as the blood pressures for the child. So, you know, we have our little calculation, but if you want the more specific ones, they're right here. They also include things of pediatric cardiac arrest algorithms. It's got the 2015 update that they just recently did. The systematic approach of how to view your mega code in here. But if you just follow my basic initial impression, your primary assessment, and your secondary assessment, you're going to be just fine. Pediatric bradycardia with pulse, what to do with that. Tachycardia with a pulse, what to do with that. Management of shock after, say, a ROS, which is what we call a return of spontaneous circulation. Pediatric septic shock algorithm, and it's got a drug map in here as well in regards to what you're going to give and what you're going to give it for. It's really just a great tool to have. On the back of this as well is a copy of the Broslow tape. So it does not include medications, that's on the inside. However, the Broslow tape in regards to equipment is right here. So this is a really great resource in case someone's stealing the Broslow tape and you really need to know what size. Sometimes communication isn't the best, but they're really emphasizing that we start communicating appropriately. If you do have this, this will save you. But that's all I have for you. If you have any questions, please feel free to leave them below. I love answering your questions, especially when it comes to recertification, because let's be honest, recertification as well as just initial certification is not the most fun. You need to study a lot of material in a very short period of time. My suggestion is to get the book as quickly as possible and start your studying immediately if you know you're going to be taking the PAL certification within the month or so.